Okay, so let's really unpack this. Today we're embarking on a truly comprehensive deep dive, our mission, to dissect an infectious disease that, well, while it's often been overshadowed by Lyme disease, it's rapidly asserting itself. A complex and increasingly prevalent threat. We're talking about babesiosis. And our goal isn't just to skim the surface, it's really to extract every essential, nuanced piece of knowledge from our detailed medical source material. Think of it like a deep dive, specifically engineered so you can master this information, really understand babesiosis like an elite professional in the field.
That's precisely right. And what makes babesiosis so compelling, I think, is its nature as an emerging challenge. It's driven by these protozoan parasites. To genuinely master this topic, like you said, we need to go far beyond just, memorizing symptoms. We're going to unravel its intricate life cycle, trace its expanding global footprint, and examine the profound implications it carries, especially for our most vulnerable populations. We'll meticulously explore the factors contributing to its rise, delve into the cutting-edge diagnostic techniques, and really break down the evolving strategies for treatment and prevention. Our aim is to connect every single dot for you, including those surprising, often overlooked aspects like unusual transmission methods and the most severe complications, making sure you gain a truly professional level understanding.
Okay, so let's begin right at the beginning then. What is babesiosis at its core?
Right. At its core, this is an emerging infectious disease, and it's caused by a specific type of tiny single-celled invader, protozoan parasites, from the genus Babesia.
Babesia. Okay, so think like microscopic single-celled organisms, distinct from, say, bacteria or viruses.
Exactly. And the fundamental mechanism, the way it makes you sick, is quite direct. These Babesia parasites, they invade our red blood cells, RBCs. Once they get inside, they replicate. They multiply themselves. And this process eventually leads to the lysis. That's the rupture of those infected red blood cells.
Lysis, okay.
And it's this widespread destruction of RBCs that triggers the whole array of symptoms a patient experiences. Initially, these symptoms often present as kind of flu-like, which you can imagine makes accurate, timely diagnosis pretty tricky.
Yeah, I bet. Easily mistaken for other common viruses, maybe.
Definitely.
And here in the United States, if we're talking about the most common species, the one causing nearly all the cases, we're looking at Babesia micropi.
That's the one. B. micropi. And for most straightforward cases, the good news is the primary treatment is usually a single standard course of two specific medications, atopiquone plus azithromycin, typically taken orally.
Okay, that's the baseline.
That's the baseline, yes. But here's where that deeper professional level understanding becomes absolutely critical. We must differentiate. You have to distinguish between individuals who have a robust, functional immune system, we call them immunocompetent, and those who are immunocompromised.
Right. That difference sounds key.
It is. Immunocompromised patients face a significantly higher risk of persistent infection. That means the parasite can linger in their system for much longer. And crucially, they're also at a higher risk for developing antibiotic resistance. That can make treatment exceedingly difficult. So this dual risk means their treatment durations aren't just a little longer, they need to be substantially extended.
Wow. Okay.
And in the most severe cases, particularly for these vulnerable groups, an adjunct exchange transfusion, which involves replacing the patient's blood, that can be a life-saving intervention.
So if you're a clinician, or maybe in public health, or just someone wanting to be really well-informed, what's the immediate takeaway here? Understanding this immune status distinction, does it really change things right from the get-go?
It absolutely changes everything. The immediate recognition of a patient's immune status is paramount. It's crucial for effective initial management. It's not just a detail. It literally dictates the entire course of their treatment and can profoundly impact the patient's prognosis. This is where that clinical vigilance really pays off. What's also critically important to remember is that, unlike many infectious diseases we know, there's currently no vaccine available for babesiosis.
No vaccine?
None. Nor is there a specific prophylactic drug to prevent infection beforehand. This means prevention strategies rely almost entirely on, physical measures, minimizing exposure to the ticks that carry the parasite.
Right. Avoidance is key then. Okay, so how exactly does this parasite make its way from, the wild into humans? Let's trace the pathogen. Where does it come from? How does it spread?
That's a fascinating question, and it really reveals this intricate web of nature. Only a select few Babesia species have actually been identified as capable of causing human illness. They act as what we call human etiologic agents. These parasites typically reside in wild or sometimes domesticated mammals. Think small rodents like white-footed mice or even cattle. They serve as the natural reservoir hosts. The parasite is then maintained in its enzootic cycle by ticks, meaning the ticks get infected by feeding on these reservoir animals.
Okay.
And then they can transmit the parasite to another animal, or, inadvertently, to a human.
Yeah.
Humans are considered incidental, dead-end hosts.
Dead-end hosts. What does that mean exactly?
What that means for us is that while we can get infected and fall ill, we don't really contribute to maintaining the parasite's natural life cycle. A tick can't really pick it up from us and spread it further to other animals effectively.
I see. Okay, and specifically within the United States, where is B. microti the main culprit, most prevalent? Where should we be most concerned?
Geographically, the overwhelming majority of cases, we're talking about 95%, are reported from the Northeast and the upper Midwest. To be precise, there are 7 highly endemic states that consistently report the highest numbers: Massachusetts, Rhode Island, Connecticut, New York, New Jersey, Minnesota, and Wisconsin. This geographical concentration is really crucial for understanding regional risk.
Absolutely.
And while B. microti accounts for nearly all human babesiosis cases here, it's important for that elite professional understanding to know that other babesiosis species can also cause human disease in the U.S. It's just much less frequent. For example, symptomatic infections with Babesia duncani and B. duncani type organisms, they've been reported from the West Coast states, Washington, Oregon, California. And then we have Babesia divergens-like organisms. They've been documented not only in Washington state, but also in some central U.S. states like Arkansas, Missouri, Michigan, and Kentucky. So this awareness of regional variants is really key for accurate diagnosis.
Okay, now looking at the incidence trends, the numbers seem to tell a pretty stark story, right? It became nationally notifiable in 2011.
That's right, January 2011. States have to report cases to the CDC now.
And since then, we've seen a dramatic surge.
We have. For instance, in 2018, there were 2,161 cases reported from 28 states.
Wow. Compare that to 2008, before it was nationally notifiable. Only 624 cases were known then, mostly from those 7 highly endemic states.
Correct. And go back another decade to 1998, the number was just 230. So yes, that's a significant, undeniable increase.
So why? Is it just better reporting, or is something else going on?
Well, this upward trend isn't just about improved reporting, though that plays a part. If we connect this to the bigger picture, the primary drivers behind this rise seem to be twofold. First, an increased density of ticks in areas where the disease is already endemic. And second, a steady expansion of the geographic range of those tick populations.
It's because we're spreading out more.
Exactly. And what's truly fascinating here, and a critical insight, is the complex ecological relationship between B. microti and Borrelia burgdorferi, the bacterium that causes Lyme disease.
Ah, the Lyme connection.
Yes. Both parasites are maintained in their natural life cycle by the same primary vector, the black-legged tick, Ixodes scapularis, the deer tick. However, the geographic expansion of babesiosis has actually lagged behind that of Lyme disease.
Oh, that's interesting. Why?
It's thought to be due to the poor ecologic fitness of B. microferi compared to B. burgdorferi. It might not adapt or spread as readily in new environments. And here's the really intriguing twist. B. burgdorferi actually seems to help maintain B. microferi in its enzootic cycle.
Wait, the Lyme bacteria helps the Babesia parasite. How?
It suggests this complex, almost symbiotic interplay between these two co-infecting pathogens within their natural environment. It really highlights the intricate dynamics of these tick-borne diseases. It's not simple.
Definitely not simple. So it's not just more ticks or ticks moving around. What other factors are contributing to this rise in human cases?
Absolutely. Other significant contributing factors include increased exposure of human populations to ticks. This is largely due to things like forest fragmentation in suburban areas.
Urban sprawl, basically.
Pretty much. As our developments encroach upon natural habitats, people and ticks inevitably come into closer contact. Additionally, our modern lifestyles often mean individuals spend more time doing leisure activities in grassy or wooded areas. Hiking, gardening, camping.
Or just being outdoors more in those environments.
Which inherently increases their chances of encountering infected ticks.
And here's where it gets really interesting. You touched on this idea of the hidden burden. Looking at antibodies in the blood, seroprevalence, paints a different picture than just reported cases, doesn't it?
Yes, this is a critical point for understanding the true epidemiology. The seroprevalence of antibodies specific for B. microti has been found to be remarkably high, sometimes up to 9% among residents in highly endemic states, especially in areas with the highest documented incidence. Similar rates have also been noted among blood donors in these regions.
9%. That's way higher than the reported case numbers suggest.
Exactly. This high seroprevalence strongly indicates that babesiosis is significantly underreported in surveillance data, and/or that asymptomatic infection, getting infected without showing symptoms, is far, far more common than we currently recognize.
So a lot of people might have had it and never even knew.
Precisely. A substantial portion of the population in these endemic areas may have been infected with Babesia without ever developing noticeable symptoms or seeking medical attention. And this has significant implications for public health surveillance, for future disease projections, and critically, for blood safety.
Blood safety.
Yeah.
Yeah, let's talk about that. You hinted at it, and this seems truly fascinating for mastering this topic. While ticks are the main culprits, babesiosis has some surprising and frankly scary alternative ways it can spread.
Yes, the primary and most common mode of transmission for B. microti is, indeed, during the blood meal of an Ixodes scapularis tick. However, a crucial detail to remember, only about 45% of patients diagnosed with babesiosis actually recall a tick bite within the 8 weeks before their symptoms started.
Less than half.
Yeah.
So most people don't even realize they were bitten.
That seems to be the case, which makes a travel history or simply knowing if you live in an endemic area even more vital clues for diagnosis.
Okay. So which specific tick stages are most responsible for passing it on?
Both nymphs and adult ticks are capable of transmitting B. microti. However, the nymphs are considered the primary vector for human infection. They're most active from late spring to early summer. They account for roughly 3/4 of all tick-borne cases that present between June and August.
So summer is peak season because of the nymphs.
Primarily, yes. Patients who present later, say late summer or early fall, likely got B. microti from an adult female tick. An important biological detail here. Tick larvae are not infected because B. microti is not transmitted transovariously.
Transovariously, meaning
Meaning the parasite isn't passed directly from the mother tick to her eggs. The larvae have to get infected themselves by feeding on an infected host first. As for other Babesia species in the U.S., Babesia duncani is thought to be transmitted by Dermacenter albipictus, the winter tick, and Babesia divergens-like organisms by Ixodes dentatus. This species-specific vector knowledge is vital for targeted prevention and understanding local risks.
Okay, now here's where we uncover that really critical, often unexpected mode, blood transfusion. This sounds like a major public health issue.
It is an absolutely paramount point for any professional understanding babesiosis. More than 300 cases of transfusion-transmitted babesiosis due to B. microti have been reported. It's a significant concern for blood safety. The vast majority result from transfusing packed red blood cells, although a few have been linked to whole blood-derived platelets that were contaminated with residual red cells.
And the parasite can survive in stored blood.
That's what's particularly alarming. B. microti shows remarkable viability within refrigerated RBC units. It can remain viable throughout the entire shelf life, which can be up to 42 days. This means transfusion-transmitted babesiosis poses a year-round threat. It's completely independent of the seasonal peaks of tick-borne cases.
Because asymptomatic carriers can donate blood.
Precisely. And their infection can persist for over a year, totally unknown to them or the blood banks. While tick-borne cases peak in summer, 3/4 of transfusion-transmitted cases are diagnosed later, June through November. And just like tick-borne cases, the incidence of transfusion-transmitted babesiosis has seen a sharp increase over the past 15 years. Over 85% occur in residents of highly endemic areas, but it's crucial to understand they aren't exclusive to these regions.
So contaminated blood could travel.
Yes, cases can occur in non-endemic areas when contaminated blood products are imported, or when asymptomatic carriers donate blood in non-endemic areas.
That sounds like a really critical vulnerability in our blood supply system.
It undeniably is. B. microti has, in fact, been identified as the pathogen most frequently implicated in investigations of transfusion-transmitted illnesses. Looking at data from 2010 to 2016, it accounted for a sobering 1/4 of all transfusion-related deaths caused by microbial infection.
1/4.
Yeah. And while B. microti is dominant here, it's worth noting Babesia duncani has also been implicated in 3 transfusion cases, though the source wasn't thought to be imported RBCs in those instances. It highlights the issue extends beyond just one species. This understanding is absolutely vital for blood bank professionals and clinicians.
Okay, moving on to even rarer, but important, routes. Vertical transmission, mother to child.
Vertical transmission, meaning passage across the placenta from mother to unborn child, has been documented, but it seems quite rare. Most reported cases in neonates infants under 1 month old are actually acquired through blood transfusion or a tick bite after birth. Infants under 1 year account for less than 1% of total annual cases reported to the CDC, so rare relative to the other routes.
And finally, an exceptionally unusual mode that really underscores the parasite's cunning nature, solid organ transplantation.
This very unusual mode was specifically highlighted in a detailed single case report. It described 2 patients diagnosed about 8 weeks after receiving a kidney allograft, a transplanted kidney, from a single deceased donor. This donor had received multiple transfusions shortly before death.
Okay, so the donor likely got it from the transfusions?
That's the strong suspicion. And the critical analytical point here, what makes this so insightful, is that corneas from the same donor were also transplanted into other recipients. But neither of those cornea recipients got infected.
Ah, so it wasn't systemic in the donor, it was likely in the kidney itself.
Exactly. It strongly suggested the source was residual red blood cells remaining within the vasculature or fluids of the donated kidneys. These less common routes, especially transfusion and transplantation, really underscore the subtle yet significant cunning nature of the parasite and the constant vigilance required in sensitive healthcare settings. It's about knowing those silent threats.
Definitely. So it's clearly not just a U.S. story. This is truly a global challenge, right? With different Babesia species making their mark across continents, each presenting diverse clinical pictures and patterns.
Precisely. The patterns vary significantly by geography and by the dominant Babesia species in a given region. If we connect this to the bigger picture, it strongly suggests that Babesia species continue to emerge worldwide. This global emergence makes international awareness and collaboration absolutely critical.
Okay, let's start our global tour of Europe. Some of the earliest documented human cases were there.
That's right. In Europe, over 40 cases have been attributed to Babesia divergens since the first index case reported from Croatia way back in 1957. B. divergens is primarily a parasite of cattle, and its main vector is the sheep tick Ixodes ricinus. Most cases occurred in Ireland and France, and, as you might expect, given its cattle reservoir, they're more common in cattle farming regions. Isolated cases have popped up across Europe, though Finland, Sweden, Spain, Russia, Georgia. A critical insight here. B. divergens infection is rarely diagnosed in immunocompetent individuals in Europe. The vast majority of patients are asplenic. They lack a functional spleen.
Asplenic, that keeps coming up as a major risk factor.
Absolutely. It underscores that key vulnerability. Beyond B. divergens, there have been 5 reported cases caused by Babesia venatorum in Italy, Austria, Germany, Sweden, and a unique single case of Babesia crassa-like organism infection in Slovenia. All 6 of those patients, the B. venatorum and the B. crassa-like, had also undergone splenectomy.
Again, the spleen connection.
Reinforcing its critical role. B. venatorum is naturally found in roe deer, while B. crassa is a sheep parasite. Ricinus is the suspected vector for B. venatorum in Europe, and Haemaphysalis ticks for the B. crassa-like organism. Also worth noting, a German patient presumably got B. microti via platelet transfusion. Global reach of that issue. And interestingly, patients with mild B. microti babesiosis in eastern Poland were immunocompetent and had intact spleens, suggests significant diversity in presentation, even for the same species, depending on geography or other factors.
Fascinating diversity. Now, shifting focus to Asia, it's gaining significant ground there too.
Yes, in Asia, B. microti was first definitively recognized as a human pathogen in Taiwan in the late 1990s. More recently, over the past decade, babesiosis has rapidly gained status as an emerging infectious disease across mainland China. For instance, in Heilongjiang province, both B. venatorum and B. crassa-like organisms have been identified causing mild disease in immunocompetent folks. Meanwhile, antibodies for B. microti have been detected in blood donors there, again emphasizing that hidden burden we discussed, widespread asymptomatic exposure.
And the ticks involved there.
The taiga tick, Ixodes persiculatus, is a known vector for B. microti and presumed for B. venatorum there. For B. crassa-like organisms, they've found them in I. persiculatus and Haemaphysalis cancina ticks. Isolated human cases due to B. divergens have also popped up in Shandong and Gansu provinces.
Right.
B. venatorum infection in Xinjiang Autonomous Region too. Beyond China, several B. microti cases reported from Yunnan province, where notably 2 patients were co-infected with Plasmodium species malaria parasites.
Malaria co-infection, that must really complicate diagnosis and treatment.
Absolutely. A significant layer of complexity where both diseases are endemic and have overlapping symptoms.
What about other parts of Asia, like Japan and South Korea?
Japan reported a single documented case acquired via blood transfusion caused by a B microtoid of the Kobe lineage. Suggests specific genetic variants might exist regionally. In South Korea, 2 cases reported, both in splenectomized individuals, again, the spleen, caused by Babesia motasi-like organisms. These are primarily sheep-goat parasites. Haemophilus longicornis was the presumed tick vector in one case.
Okay. And beyond Europe and Asia, the rest of the world?
Less frequently reported, but B microtoid infection documented in New South Wales, Australia, and Manitoba, Canada. Though serosurveys suggest it's not truly endemic there, it may be isolated or travel cases. 3 B microtoid cases reported from Yucatan, Mexico. What's truly fascinating here, and critical for understanding Babesia's broader potential, is definitive evidence that Babesia bovis and Babesia bigemina species, mainly known in cattle, can also cause human illness.
Cattle parasites jumping to humans.
Evidence comes from Araba, Colombia, a region with cattle ranching, also endemic for malaria, highlights that zoonotic risk, especially in agricultural areas. B. bovis is also presumed to have caused disease, sometimes death, in Mozambique. And in South Africa, 2 patients diagnosed after visiting malaria endemic areas in Namibia and Zimbabwe. This global spread, multiple continents, various species, powerfully reinforces that idea. Babesia species continue to emerge worldwide, a truly international challenge. Understanding these global nuances is essential for any pro in this field.
Absolutely essential. Okay, we've established what babesiosis is, how it spreads globally. Now, let's dig into a critical question for any elite professional. Who gets hit hardest? It's not random. There are clear risk factors.
That's an excellent point. Absolutely crucial for understanding impact and targeting strategies. When we look at symptomatic individuals, the data shows most around 80% are 50 or older. For patients needing hospitalization, their median age is even higher, typically 68, compared to 59 for non-hospitalized. Now, while being over 75 is a risk factor for hospital admission, it's important to distinguish. It is not by itself a direct risk factor for severe babesiosis outcomes.
Okay, so age isn't the sole predictor for a really bad outcome. What are the major risk factors then?
The 2 overarching most significant risk factors for severe babesiosis are asplenia and immunosuppression.
Asplenia again. Lack of a functional spleen.
Exactly. Can be congenital, born without one. Functional spleen present but not working right, like in celiac disease, sickle cell, thalassemia, or most commonly acquired via splenectomy surgical removal. The spleen plays an absolutely critical dual role. It filters out parasitized red blood cells, and it's vital for initiating the protective immune response. So when that organ is absent or compromised, the body's primary defense against babesia is severely impaired. Parasitemia can rapidly escalate.
Makes sense. And immunosuppression, how does that play in?
Immunosuppression very often is iatrogenic, meaning it's a consequence of medical treatment. Common in patients getting therapy for autoimmune disorders, chronic inflammatory conditions, cancer, or organ transplant recipients on anti-rejection meds. But it can also be inherent due to underlying conditions like certain immunodeficiencies or HIV/AIDS. In all these cases, the weakened immune system simply can't mount an effective, timely response. Leads to higher parasite loads, more extensive red cell destruction, and a more severe protracted illness.
And thinking back to transfusion-transmitted babesiosis, what are the specific risk factors for getting it that way?
For transfusion-transmitted cases, the risk factors are, quite logically, any medical condition needing a blood transfusion. This includes hematologic disorders, anemia of prematurity in infants, significant bleeding during surgery, severe gastrointestinal diseases causing blood loss. What's truly fascinating, connecting the dots, is how these underlying vulnerabilities link back to the body's fundamental defenses. The spleen, crucial filter, immune initiator. When that defense is compromised, physically absent spleen or suppressed immune system, the Babesia parasites just multiply much more easily, leading to more destruction, more severe systemic illness. Understanding why these conditions make people vulnerable is key to mastering babesiosis.
Absolutely. Okay, let's delve into the clinical landscape now. What does babesiosis actually feel like? How does it progress? Let's start with B. microtodia, the most common one in the U.S.
Right. For B. microtodia, symptoms typically appear 1 to 4 weeks after an infected tick bite. But if acquired via contaminated blood transfusion, the onset can be significantly later, usually 3 to 7 weeks, median 37 days, but it can range widely 11 to 176 days. Patients usually describe a gradual onset, fatigue, maybe general malaise. Then, within a few days, fever plus 1 or more hallmark symptoms. Chills, drenching sweats, headache, myalgia, muscle aches. The fever can be persistent or intermittent, sometimes really high, up to 40.9 degrees C, that's 105.6 degrees Fahrenheit, reflects that intense inflammatory response.
Are there other, less common but still important symptoms to watch for?
Yes, certainly. Less common ones include anorexia, loss of appetite, arthralgia, joint pain, nausea, a persistent dry cough, neck stiffness, sore throat, emotional lability, vomiting. Even rarer, diarrhea, crampy abdominal pain, joint swelling, dark urine, that's hemoglobinuria from RBC lysis, and shortness of breath. So a comprehensive history is vital given this wide spectrum.
And what would a clinician look for during a physical exam?
On physical exam, fever is almost always the most salient feature. Skin might look pale or yellowish anemia and jaundice from RBC destruction. A focal red rash might mark the tick bite site. And critically, seeing an erythema migrans rash, the classic bullseye, signifies co-infection with Lyme or maybe Starry.
Ah, the co-infection clue again.
Exactly. Scleral icterus yellowing of the whites of the eyes, strong visual indicator of severe hemolytic anemia. More rarely, retinopathy with splinter hemorrhages or retinal infarcts indicating microvascular issues. Tenderness in the upper left abdomen suggests splenomegaly, enlarged spleen, maybe with hepatomegaly, enlarged liver.
You mentioned splenic complications early, like rupture. What are the warning signs for that?
Yeah.
Really serious stuff.
Yes. Abdominal pain, especially upper left quadrant, or unexplained hypotension, dangerously low blood pressure with tachycardia, a rapid heart rate, should immediately raise suspicion of splenic rupture and internal bleeding. It's also crucial for professionals to know that splenic infarction tissue death due to blocked blood flow and subcapsular hematoma bleeding under the spleen's capsule can occur even without a full rupture. Both suspected infarction and rupture are typically confirmed quickly with a CT scan, vital for immediate management.
Okay. And how do we define severe babesiosis? What signals a truly critical case?
Severe babesiosis means needing hospital admission, especially ICU, or having specific severe complications. For context, about half the CDC reported cases between 2011 and 2015 needed hospitalization, median stay 4 days. Severe cases can manifest with major complications. Common ones are severe anemia needing transfusion, ARDS, acute respiratory distress syndrome, significant renal insufficiency or kidney failure, liver dysfunction, congestive heart failure. Less common, but equally serious, DIC, disseminated intravascular coagulation, profound shock, splenic rupture. From a diagnostic timing perspective, patients diagnosed more than 7 days after symptoms start are statistically predisposed to severe disease.
So early diagnosis is key. Any initial symptoms predict severity.
Yes, among initial features, diarrhea and nausea vomiting are strong independent predictors of severe babesiosis. As we discussed, underlying conditions like asplenia and autoimmune disorders clearly predispose to severe disease. Interestingly, though, underlying heart conditions don't seem to increase that risk.
And here's that counterintuitive insight about Lyme disease again. You'd assume co-infection makes babesiosis worse.
This is a critical nuance, and you're right, it's counterintuitive. What's truly fascinating is that co-infection with Lyme disease, Borrelia burgdorferi, does not actually increase the risk of severe babesiosis. In fact, clinical observations suggest it tends to decrease both the number and duration of symptoms specifically caused by babesiosis.
So Lyme might mask the babesiosis symptoms.
That's the profound implication. Babesiosis might be overlooked or misdiagnosed if it's accompanied by concurrent Lyme, could lead to delayed diagnosis and treatment for the babesiosis part. A real game changer for clinicians always consider babesiosis if Lyme symptoms aren't resolving as expected.
Despite treatment, it can be fatal. What do the mortality stats show?
The stats are sobering, especially for vulnerable groups. A review of over 10,000 Medicare recipients, 2006-2013. 1% died within 30 days of diagnosis. Among inpatients, 3%. More recent CDC data, 2011-2015. Overall rate, 0.6%. However, death rates are significantly higher among immunocompromised patients, around 20%, underscores their extreme vulnerability. Also markedly elevated among those who get it via blood transfusion. One series reported 17% fatality, another more recent one showed 5%. Significant numbers underscoring the seriousness, especially in high-risk groups.
Okay. Moving beyond B. microti, what about other Babesia infections in the U.S. and globally? Do symptoms or severity vary much by species?
They absolutely do. Understanding these variations is crucial for a comprehensive grasp. In the U.S., for instance, the 8 documented Babesia duncani cases were moderate to severe, 1 death. Symptoms generally similar to B. microti. For the 6 patients with Babesia divergens-like organisms, all were severe, needed hospitalization, 3 died. Highlights a particularly virulent form.
And globally, how does the picture change?
Globally, it definitely shifts. In Europe, most Babesia divergens cases occurred in splenectomized individuals, and they've been uniformly severe. Symptoms hit suddenly. Very high fever, over 41 degrees C, 105.8 degrees epinerval, intense shaking chills, drenching sweats, severe headache, myalgia, lumbar abdominal pain. Jaundice and hemoglobinuria are common. Critically, without immediate aggressive therapy, patients often rapidly develop life-threatening pulmonary edema, acute renal failure.
Real emergency then.
Absolutely.
Mm.
For Babesia venatorum in Europe, 5 cases reported, also in splenectomized patients. Illness ranged mild to severe, but thankfully no deaths reported, potentially less virulent than B divergens.
That's quite a contrast.
Right.
What about those B. venatorum, B. crassa-like infections in China you mentioned earlier? In spleen-intact people.
This is where we see a fascinating aspect of the spectrum. In northeastern China, the 32B venatorum cases were in spleen-intact residents. Symptoms similar to B. microti, though chills were rare. 7 hospitalized for irregular fever. Only 4 treated, yet remarkably, all 32 recovered fully. Similarly, the B. crassa-like cases there were also in spleen-intact folks. Fever, fatigue, myalgia, less common than B. microti, nausea vomiting more common. No hospitalizations. Only 3 of 31 treated, yet symptoms resolved in most.
So some species, in some places, can cause milder self-limiting illness.
That seems to be the critical insight here. It suggests some Babesia species, perhaps in specific regions or populations, can behave differently, especially in immunocompetent hosts. Finally, the 2 Babesia motasi-like cases in South Korea were severe. 1 death, 1 recovered after treatment. These diverse presentations and outcomes across species and geographies really underscore the paramount importance of species identification and understanding the geographical context, essential for predicting progression and outcomes. This deep understanding defines an elite professional.
Absolutely. Okay, we've seen the symptoms, the complications. But how exactly do these parasites wreak such havoc? It's this complex interplay, right? Direct damage plus the body's own immune response, which can be a double-edged sword. Let's start with the central issue, anemia.
Hemolytic anemia is indeed the cornerstone. When red blood cells are invaded and lysed, ruptured by Babesia, it releases cellular debris into the bloodstream. This debris, if not cleared efficiently, can accumulate in the kidney, potentially leading to acute renal failure, a life-threatening complication. Furthermore, when RBCs decise, they release hemoglobin. Hemoglobin normally complexes with haptoglobin, which helps clear it, but even minute amounts of free hemoglobin promote widespread systemic inflammation.
So it's not just cells bursting. How else do red cells get damaged or removed?
What's truly fascinating is that infected RBCs, under the oxidative stress of infection, become poorly deformable. They lose flexibility, struggle to squeeze through narrow capillaries, especially in the spleen's red pulp. As a result, these rigid infected cells are more easily recognized, filtered out, and engulfed by splenic macrophages, a process called erythrophagocytosis.
Erythrocytosis.
Okay, this excessive removal contributes significantly to splenomegaly and large spleen and can even lead to splenic rupture in severe cases. In rare but often fatal instances, this excessive immune activation can lead to hemophagocytic lymphohistiocytosis, where immune cells destroy not just infected cells but healthy ones too, causing severe organ dysfunction.
So anemia in babesiosis is much more complex than just direct parasite action.
Exactly. Anemia is also significantly worsened by suppressing erythropoiesis, the production of new red blood cells in the bone marrow. This suppression is a direct consequence of inflammatory cytokines, particularly interferon gamma, IFN, and interleukin, IL-6. These cytokines, while key for immunity, can also harm bone marrow function. Plus, even after the infection resolves, persistent anemia can sometimes occur. This is due to autoantibodies mistakenly tagging healthy RBCs for clearance, possibly activating the complement system, further worsening anemia.
Which brings us directly to inflammation. The immune response, meant to protect, can cause collateral damage.
It truly is a double-edged sword. The spleen, as we've said, is crucial, clearing infected RBCs and providing protective immunity. That's why asplenia is such a major risk factor. From a cellular immunity view, protection mainly involves CD4 plus T cells, especially Th1 cells. Mouse models clearly show this. Deplete CD4 plus cells or neutralize IFNO, and you get high-grade persistent parasitemia. This is corroborated by the severe course seen in patients with AIDS or allograft recipients. Their immune systems are compromised.
And those flu-like symptoms, fever, chills, sweats, They're part of this broader inflammatory response.
Absolutely. Direct manifestation of a systemic inflammatory response. Cytokines like TNF-alpha and IL-6 have been detected in patients' blood. What's truly fascinating, a key insight into pathogenesis, is that while some inflammation is needed, excessive inflammation promotes pathology, worsens outcomes. For example, in a mouse model of B. duncani, high TNF-alpha in the lungs led to pulmonary edema. Blocking TNF-alpha rescued the animals. Even in B. microcy mice without pulmonary edema, TNF-alpha was detrimental. Faster parasite clearance occurred without its receptor. Shows a delicate balance. Needed, but too much is damaging.
What about humoral immunity? Antibodies, do they play a big role in clearing the parasite?
The role of humoral immunity, B cells, and antibodies is a bit more nuanced, uncertain. We know nearly every immunocompetent patient has detectable antibodies at diagnosis. However, the observation that rituximab, a drug that depletes B cells, predisposes patients to persistent or relapsing babesiosis. That strongly indicates B cells, and presumably antibodies, are critical for clearance in at least some individuals, especially those already compromised. Suggests that while antibodies are present, their exact role might vary depending on the host's overall immune status and the specific Babesiosis species. Still needs more research for a complete picture.
Okay. So if someone presents with compatible symptoms, how do medical professionals definitively confirm it's babesiosis? The diagnostic journey sounds intricate. Need a keen eye, precise tools.
Right. When considering babesiosis, it should be high on the list for any patient with compatible symptoms who either lives in or recently traveled through an endemic area, especially late spring to early fall. Or, importantly, anyone who received transfused blood components, especially packed RBCs, in the past 6 months. Careful history taking is the critical first step.
And given that high likelihood of co-infection with Lyme, how does that factor in? This seems really crucial for clinicians.
Absolutely critical, demands high clinical suspicion, integrated thinking. Since about 10% of Lyme patients are also infected with B micro-T, and co-infected patients usually have longer, more severe illness than Lyme alone, babesiosis should be actively considered for any patient diagnosed with Lyme, especially if symptoms worsen or just don't get better after starting Lyme antibiotics.
Makes sense. Check for Babesia if Lyme treatment isn't working as expected.
Exactly. And conversely, since about half of babesiosis patients are also infected with Borrelia burgdorferi, a babesiosis diagnosis should immediately prompt evaluation for Lyme disease. Plus, consider other tick-borne diseases sharing vectors or geography anaplasmosis, ehrlichiosis. A single tick bite can transmit multiple things. This integrated, multi-pathogen approach is essential in endemic regions.
Beyond just suspicion, what do routine lab tests typically show that might point towards babesiosis?
Routine labs often provide important clues. A CBC commonly reveals anemia mild to severe. An elevated reticulocyte count is key, signifies stress-induced red blood cell production trying to compensate. Low haptoglobin or elevated LDH are consistent with hemolytic anemia, ongoing RBC destruction. Interestingly, severe thrombocytopenia low platelets is often seen and can precede severe anemia. White blood cell count varies reduced, normal, or elevated.
And markers for organ damage, liver, kidneys.
Chemistry often shows elevated AST and ALT indicating liver cell injury. Elevated total bilirubin results mainly from hemolysis, but can also signal liver compromise. Elevated BUN and creatinine are key indicators of kidney compromise. Urinalysis might show excess urobilinogen, hemoglobinuria, hemoglobin in urine from lysis, and or proteinuria, protein in urine. A special consideration, a critical aha moment for clinicians. Babesiosis can mimic HELLP syndrome.
HELLP, that's a pregnancy complication, right?
Yeah.
Hemolysis, elevated liver enzymes, low platelets.
Exactly. So babesiosis should be strongly considered for pregnant women at risk of tick exposure who present with lab abnormalities defining HELLP syndrome, a serious mimic.
Is there consensus on specific lab parameters that reliably predict severe babesiosis?
Not a universally agreed upon single set, as studies vary slightly. But several strong indicators exist. One study found total bilirubin 1.9 mg/dL, highly predictive of severe outcome. Interestingly, lower WBC counts, 5, IL-1 and 3L, were associated with better prognosis in that study, maybe less inflammation. Conversely, other parameters linked to severe disease included parasitemia 10% at diagnosis, WBC counts 10 out of 1 of 3L, and creatinine 1.2 mg/dL, kidney issues. An earlier study flagged alkaline phosphatase 125 IUL and WBC counts 5 out of 103 ABL as strong predictors of severe disease, defined then by long hospital ICU stay or death. Parasitemia 4% at admission was also associated there. So while no single magic marker, these lab abnormalities collectively point towards increased likelihood of a severe course.
Okay, routine labs give clues, but what about the specific definitive tests, the undeniable proof?
Definitive diagnosis comes from one of two primary methods: microscopic examination of germ-sustained thin blood smears, or amplification of Babesia DNA via PCR. On a germ-sustained smear under the microscope, Babesia trophozoites appear as characteristic round, oval, or amoeboid forms inside red blood cells. The ring form is most common. Crucially, and this is key to differentiate from malaria, Babesia rings lack the central brownish hemozoan deposit typical of Plasmodium falciparum late-stage trophozoites, vital distinction where both might occur.
Good point about malaria. Any other visual clues on the smear?
Yes. For travelers from P. falciparum endemic areas who also live in a Babesia endemic area, a rapid malaria test like Binax Now W can help rule out falciparum malaria if microscopy isn't immediately available. Other distinguishing features: presence of extracellular merozotes, especially with high parasitemia, and the absence of gametocytes and schizonts, life cycle stages seen in Plasmodium, not Babesia. What's also pathognomonic, uniquely characteristic and diagnostic, is the arrangement of merozoites in tetrads, the Maltese cross formation.
The Maltese cross. Heard of that. Definitive sign.
Pathognomonic. Can be seen with B. microti, B. duncani, B. venatorum, or B. divergens-like organisms. Parasitemia level percentage of infected RBCs typically 0.1–10% in immunocompetent patients, but can skyrocket to 30–40% in severely immunocompromised patients, critical indicator of severity.
And if microscopy isn't clear, or you need the specific species, PCR.
Exactly. If parasites aren't definitively ID'd by microscopy but suspicion remains high, PCR amplification of Babesia DNA from blood is strongly recommended. Most assays target the 18S RNA gene. Sensitive ones use a fluorescent probe. Real-time PCR assays are incredibly sensitive, can detect as few as 110 parasites per microliter. This sensitivity, plus their ability to differentiate species, makes them exceptionally well-suited for speciation, vital for guiding precise treatment, especially for rarer species.
And finally, serologic testing. Antibodies. How reliable is that for active infection? What are the limits?
Serologic testing, usually IFA, indirect fluorescent antibody test, is widely used, but comes with a crucial limitation any elite professional must grasp. A single positive serologic result is not sufficient to diagnose active babesiosis.
Why not?
Because antibodies can persist for over a year after the illness resolved and the parasite cleared. For B. microti, IgM titers 1.64 and IgG titers 1.1024 suggest active or recent infection, but clinical context is paramount. Also note species specificity. B. microti antibodies don't react with B. duncani or B. divergens antigen, mean different tests. However, an interesting cross-reactivity, sera from B. venatorum or B. crassa-like infections do react with B. divergens antigen, can complicate diagnosis if not interpreted carefully. This level of diagnostic detail is key for mastery.
Definitely key. Okay, once diagnosed, how do professionals tackle this? Treatment isn't one size fits all. It changes dramatically based on severity, demanding a tailored strategy.
Right. For mild to moderate B. microtide illness, the standard most effective treatment is that combination. Oral ativaquone plus azithromycin, usually for 7 to 10 days. Guidelines give specific doses for adults, kids, bedrock for less severe cases.
And the typical clinical response in immunocompetent patients?
Usually symptoms abate quite rapidly, often within 48 hours of starting therapy. Generally resolve completely within 1 to 2 weeks. If symptoms persist despite this, essential to reevaluate. Actively test for co-infections. Lyme, anaplasmosis, they can complicate recovery. Important note though, persistent fatigue alone, weeks or months after, doesn't typically warrant extending or resuming treatment. Can be post-infectious. While parasite DNA can sometimes be detected by PCR for up to 3 months after, follow-up PCR isn't generally recommended in immunocompetent folks. Relapse is unlikely once symptoms resolve after the initial course.
Now, what about severe B. microdual illness? Treatment gets much more intensive here, requires critical care.
For severe microdual, the preferred first-line therapy is oral ativaquone combined with intravenous IV azithromycin. Efficacy supported by evidence, including a retrospective study of 40 severe patients, 11 in ICU. Infection resolved in all but one with this combo, highlights its potent effect. Historically, clindamycin plus quinine was the gold standard for severe cases.
Right, quinine, but that has issues.
Significant issues. Quinine carries risk for QTC prolongation, dangerous heart arrhythmias, plus other adverse events like synconism, tinnitus, headache, nausea, visual disturbances, often so intolerable it leads to stopping the drug.
So those drawbacks led to a major shift in preferred treatment for severe cases.
Exactly. While no trial directly compared atovaquone azithromycin versus clindamycin quinine specifically in severe babesiosis, a prospective trial showed atovaquone azithromycin is just as effective as clindamycin quinine for clearing parasites and resolving symptoms in non-life-threatening cases. Given quinine's drawbacks and frequent discontinuation, atovaquone plus azithromycin became the mainstay for treating severe babesiosis. Superior tolerability, proven efficacy in less severe cases. Worth noting, some experienced clinicians add IV clindamycin to this two-drug regimen initially, especially for severely immunocompromised patients, though this three-drug approach isn't formally trial-supported yet. And if QTC prolongation or azithromycin allergy is a concern, clindamycin can substitute for azithromycin.
How is dosing and monitoring managed for severe cases, transitioning from IV to oral?
4V azithromycin initiated at 500 mg a day with atovaquone. Labs monitor daily CBC, liver-kidney function until symptoms abate and parasitemia drops below 4%. Once improvement's seen, especially if a patient has a functional spleen and is immunocompetent, azithromycin can transition to oral, dose reduced to 250-500 mg a day. Entire regimen typically 7-10 days, extended if symptoms persist or improvement is slow. Critically, if patient is asplenic or profoundly immunocompromised, higher azithromycin dose 500 mg should be strongly considered for the entire course, not just initially, to ensure sufficient drug levels and prevent relapse.
For the most critical cases, there's that intensive intervention. Adjunct red blood cell exchange, RCE. When is it indicated? How does it work?
Red blood cell exchange, partial or complete, is indeed a crucial adjunct, recommended for patients with very high-grade parasitemia, a 10% infected RBCs, or moderate to high-grade parasitemia combined with severe complications, severe hemolytic anemia, pulmonary compromise, ARDS, renal or hepatic compromise. Therapeutic apheresis, including RCE, always done in close consultation with a transfusion medicine specialist. Complex, resource-intensive, potential risks. Main purpose is multifaceted. Actually, criteria are not as strictly defined as you might expect. Largely based on case reports, small series, not large randomized trials. Highlights the evolving nature of managing severe cases. One study showed RCE reduced parasitemia by 75%. Patient age and pre-RCE parasitemia predicted post-RCE hospital stay. But a crucial finding for professionals, post-RCE parasitemia was not significantly associated with length of stay or mortality. Argues against repeated RCE just to hit an arbitrary low parasitemia level. Decisions should primarily consider patients' overall clinical status, especially end organ dysfunction, renal, pulmonary, not just chasing a specific parasitemia number. Clinical judgment guides intensive therapy.
What about severely immunocompromised patients? Their battle sounds particularly protracted, challenging.
It is, without doubt, significantly protracted and difficult. Conditions like asplenia, rituximab use depletes B cells, HIV/AIDS, intensive immunosuppression for transplants or malignancy, all predisposed to persistent or, crucially, relapsing babesiosis. For these patients, antimicrobial therapy must be extended at least 6 consecutive weeks. Vital detail, must include 2 final weeks where no parasites are seen on blood smear. Ensures complete eradication, prevents early relapse. Given this extended duration, atovaquone plus azithromycin remains preferred due to tolerability. Azithromycin initiated 5E, 500 mg a day. Labs monitor daily until symptoms abate parasitemia 4%. Then azithromycin can go oral, but dosage rigorously not less than 500 mg a day. Lower doses might promote resistance, significant concern here. Once stable, weekly blood smears until full extended course completed. If symptomatic but no parasites on smear, use real-time PCR to monitor for low-level infection. Close follow-up after treatment. Recurrence needs immediate smears PCR.
Which brings us to a growing concern, resistance. If patients aren't responding, what's the mechanism? How do clinicians manage it?
Failure of atovaquone azithromycin has been documented, particularly in highly immunocompromised patients. Such resistance has a clear molecular basis vital for elite understanding. Atovaquone resistance. Missense mutations in the parasite's mitochondrial cytochrome B gene, COB, alters the drug target site, azithromycin resistance. Missense mutations in the apicoplast-encoded ribosomal protein subunit L4 gene, RPL4. Apicoplast is a unique organelle in these parasites. When patients are unresponsive, they can be managed with the older clindamycin plus quinine combo, but quinine toxicity.
Right, the side effects.
Exactly. So if quinine toxicity is a major concern or resistance basis is unknown, clindamycin can be added to atovaquone azithromycin for a 3-drug approach. Another alternative? Substitute atovaquone-proguanil for atovaquone. Shows the constant evolution, adaptability needed to face drug resistance, pushing therapeutic boundaries.
And finally, that critical complication, splenic rupture. How's it managed? What are the implications?
The splenic rupture typically occurs in young, healthy, immunocompetent patients, often with surprisingly low parasitemia. Challenging diagnosis. Management depends critically on hemodynamic stability, unstable or rapidly deteriorating. Emergent splenectomy surgical removal, life-saving. Stable but persistent bleeding. Splenic arterial embolization, less invasive procedure to block blood flow to damaged area. No hemoperitoneum, internal bleeding. Can sometimes be managed non-surgically but needs extremely careful, continuous hemodynamic monitoring in ICU. Crucial reminder, removing the spleen, while sometimes necessary, leaves patients permanently at significantly increased risk for relapsing babesiosis and severe disease from other microbes. Long-term implications.
Okay. While B. duncani is the main focus in the U.S., other species cause disease globally and sometimes here. They need specific treatment approaches. Global context offers insights into adaptability.
Exactly. For B. duncani and B. divergens-like infections in the U.S., typical treatment has been intensive. 5e clindamycin plus oral quinine, usually 7-10 days, extended if symptoms persist. Reflects their more severe nature compared to mild B. microtyme.
And how do global treatments for other species compare? Shows consistency and adaptation.
Globally, approaches show both consistency and crucial adaptations. In Europe, Babesia divergens infection is a medical emergency due to rapid, severe progression, especially in asplenic patients. Recommended approach: immediate, complete RCE combined with IV clindamycin plus oral quinine. Mirrors intensive U.S. approach for severe non-microsorted species. Worth noting, some cases cured with RCE and clindamycin monotherapy, no quinine, suggesting some flexibility. Anemia may persist 1 month, often needing transfusions. Interestingly, one severe B. divergens case resolved with atovaquone azithromycin, the B micro-2 regimen, indicating potential broader use, and a relapse in a spleen-intact individual was treated with atovaquone proguanil plus azithromycin, shows exploration of alternatives.
What about B. venatorum in Europe and China, where we saw some milder cases earlier?
For B. venatorum in Europe, first line has historically been ivorol clindamycin plus quinine, similar to other severe Babesia. But in a quinine-intolerant patient, infection cured with atovaquone azithromycin again, adaptability, and notably that pediatric case of mild B. venatorum in China, successfully treated by standard atovaquone azithromycin course. These global examples show how protocols reflect regional experiences, parasite strain characteristics, host immune status, continuously adapting for best outcomes. Comprehensive view means understanding the dynamic nature of treatment.
Absolutely dynamic. Okay, prevention and future outlook. Given the severity, preventing transmission is paramount, especially our blood supply, regulatory bodies, technology playing a role here.
Indeed. Given increasing incidence, high mortality of transfusion-transmitted babesiosis, the U.S. FDA took significant steps. Recommended screening blood donated in 14 endemic states plus DC for B microtide DNA using NAT, nucleic acid tests. Crucial public health intervention.
And has this led to approved tests?
Yes, major leap forward. January 2019, FDA approved an ultra-sensitive NAT detecting transcripts of the parasite's 18S RNA gene. Incredibly sensitive, aiming to catch even low parasitemia in asymptomatic donors. Strong expectation. Widespread screening, once fully implemented, will likely significantly reduce, if not prevent, transfusion-transmitted babesiosis. Also, to further safeguard, individuals with a history of babesiosis or asymptomatic infection, lab-confirmed, are indefinitely deferred from donating blood. Comprehensive, multi-pronged approach to close a critical transmission pathway. Shows how pros approach public health challenges.
Great to hear about progress there. Now, for individuals, since there's no vaccine or specific preventative drug, personal vigilance is our best defense. Key strategies, especially in endemic areas.
For individuals in endemic areas, especially those at higher risk for severe disease, several crucial steps. First, protective clothing. Long sleeves, long pants in wooded grassy areas. Physical barrier. Second, repellents. DET or picaridin on skin, treat clothing with permethrin, powerful chemical deterrent. Third, limit outdoor activities where ticks abound, especially May-October peak season. Lastly, critically, thorough skin exam after outdoor activities. Spot and remove ticks immediately. Use fine-tip tweezers, get the whole tick, don't squeeze the body. Basic, diligently applied steps are most effective currently.
Okay, so wrapping up this deep dive, what's the future hold for babesiosis? Sounds like an evolving threat needing ongoing attention.
It absolutely is. The source material critically highlights As babesiosis continues to spread into new areas, and because climate change likely will shift the boundaries of these endemic areas, individuals at risk and physicians should remain aware of this once neglected disease. What's truly fascinating, critical for future patterns, is how broader environmental factors like climate change altering habitats, temperature, humidity directly influence tick distribution in populations. This expansion means physicians in previously unaffected regions must now rigorously include babesiosis in differentials. Public and expanding risk zones needs education too, underscores the dynamic nature, continuous need to adapt knowledge, surveillance, public health strategies.
Wow, what an incredibly comprehensive deep dive into babesiosis. From that tiny tick to global spread, the intricate nuances of diagnosis, those critical evolving treatment decisions, we've truly unpacked what it takes to understand this like an elite professional. We've seen how crucial it is to consider not just obvious symptoms, but underlying risks, surprising transmission routes, the intricate ways the parasite interacts with our bodies, our immune systems.
This deep dive, I think, raises an even broader, more important question. As we move forward, with diseases like babesiosis expanding the reach climate change, human-wildlife interaction, how might our fundamental understanding of an endemic disease need to evolve? And what does it truly mean for our public health systems to be comprehensively prepared for these emerging threats, especially when they present with such a wide spectrum, require such nuanced approaches? Consider this. The knowledge we've gained today isn't just about Babesia specifics. It's a powerful illustration of how interconnected our individual health, our global environment, and our collective vigilance truly are.
We hope this deep dive has empowered you with the knowledge to observe your surroundings with new eyes, be more acutely aware of your health, and appreciate the profound ongoing effort needed to understand and combat complex diseases like babesiosis. Remember, being truly well-informed, mastering these challenges, it's a continuous, vital journey.